So good morning all. I'm Dr. Krishna Prasad. I'll be speaking on my little experience with the new trifocal IOL, the Optiflex Trio from the biotech. And let me thank the Coscon officials and Dr. Ilan Kumar in particular for my inclusion. So we have come a long way for in the evolution of cataract surgery. And what we are looking for is the refractive technologies to an ultimate aim of spectacle independence with a spotless vision. I think we always had some refractive surgery to help us for myopia and hyperopia. We had a lot of cornea-based procedures and lens-based procedures, including a refractive lens exchange. For presbyopia, the history had seen many surgeries and many laser procedures, and some of them were successful, some were failures. And now the cataract surgery has married the refractive surgery, and that has come out as probably the answer for the presbyopia correction. And maybe in the future, cataract may not be an indication to remove the lens. It may be even a presbyopia for that matter. So then we had like the black and white television, which used to have a lot of static disturbances with the antenna turning around. And people were very happy with whatever they could little see on the television sets. But today we have the latest HD large screens with impeccable quality. So obviously things have changed now. Today's patient, even in our cataract surgery domain, is very selective. He's expecting a lot. Around 70% of patients expect to be free from spectacles, even though even a monofocal intraocular lens implantations, making them a metrope, also have some amount of pseudo accommodation, and most of them do have some spectacle independence. But an absolute clear vision for near and intermediate distance is what most patients, around 70%, want, and the other 30 will be probably happier if they can be provided with that. So it's sometimes the patient's level of expectation which can change the statistics, but no matter what, everybody wants to see clearly at the end of the day. So obviously they want to get back to their active lifestyle. Even the older population would like to go back to their gadgets, would like to see things on the screen very clearly without looking for their glasses, and the youthful vision at all lighting conditions. This is very important. So even with the mesopic and scotopic conditions, they should retain some active near vision. So from being a safe surgery to an efficient surgery, we took care of emmetropia so that spectacle could be taken away for distance. With toric lenses, we could take care of the corneal astigmatism. But now, absolute spectacle independence. That means near and intermediate, which has gained a lot of importance in today's life, and the distant vision. A complete spectacle independence should be the driver for today's good outcomes in cataract surgery. So obviously, when you choose a lens, it is a material, the design, and obviously the cost, which is still the driver. And obviously, you have to look at the wound size. What is the wound size that is required? What is the insertion? There are a lot of lenses which are so difficult to insert. They are fraught with complications of damage to the lens during the insertion. There are categories which you can't fathom, you can't figure out how to use them. There are a lot of problems sometimes with the implantation itself, and also how the lens behaves within the eye. What are the inflammation? What is the PCO rate, which is a very important thing. I think PCO rate is going to drive the surgery today, because any incidence of PCO, higher incidence of PCO, will definitely take the sheen out of the cataract surgery. By 6 months, 1 year, patients are not happy, and obviously they may think there's something wrong with the surgery, whereas it's just the material of the lens which is causing this problem, which should be absolutely avoided. And obviously, dysphotopsia, photic phenomena, lens glistenings even can be a bothersome thing, and spectacle independence, obviously the center stage or the most important expectation of the patient. Patient obviously has to be motivated for the spectacle independence, and lifestyle basically decides what kind of lenses that he may actually be better with. The previous refractive error, it's all said that the people who have been really dependent on glasses will be a lot happier with the spectacle independence post-surgery, and especially hyperopes and people who do have less expectations from their post-op vision will be a lot happier. The patient psyche is the most important thing, and the cost obviously is the thing that patient takes into account. So you have refractive lenses, diffractive lenses, bifocals. You have head-off lenses now, which are basically something between the typical trifocals and the monofocal, which is basically a compromise on either side. But the real spectacle independence comes from a trifocal IOL, in which the intermediate distance has been managed to be around between 60 to 80% with the most physiological positions, and you have almost the toric options for a significant astigmatism. So today's topic will be on my experience with the new kid on the block from the biotech. We have an OptiFlex Trio, the trifocal, which is coming from the biotech, which has already released a lot of very successful lenses in the monofocal and the toric segment. So obviously you need to understand a full optic diffractive, which has, rings, the entire optic. There's definitely going to be a lot of light loss, a definite compromise in the contrast sensitivity, and the positive dysphotopsia may increase. Nevertheless, the advantage is probably the near vision may be a lot better, but probably if you have a small diffractive zone, less than 4 millimeters, there's always a compromise in the near and intermediate performance. The less rings, less near vision, more rings, more near vision, but basically the balance is around 4 millimeters, which should work in all lighting conditions and all pupils. So I think this is just an indication that a trifocal checks into all the overall requirements that we need in a bifocal in a patient. So coming back to the candidate in question, the OptiFlex Trio, we were also little gingerly, we tried this lens with a lot of caution, but I should say at the end of the day that we have been really happy with the result. It's a true trifocal, which gives 3 definite focal points. Plus 3.5 is the basic beauty, because the near vision, especially people who are reading small print, the newsprint, the reading speed for a newsprint is the criteria, and plus 3.5 is an excellent, add at the IOL plane, which gives you around 2 to 2.75 at the corneal plane, around 1.85 for intermediate distance, which covers most of the ranges anywhere from 35 centimeters. This is very important. So even closer to the eye, you can actually see up to 90 centimeters. Whereas the most physiological intermediate vision is somewhere between 60 to 75 centimeters. And the light distribution is very important. 45% for distance, 27 for intermediate, and 28 for near. Normally, the earlier lenses used to compromise in the intermediate, but now that has been given a lot of importance. And almost 88.3% light transmission. So the light loss, so the loss of contrast is a lot less compared to the predecessor lenses and other, trifocals or multifocals even. And the rings are 12. So that indicates that there are enough near opportunity for the patient to see. But the innermost zone without any rings is around 1.12, which fits into the most of even the small senile pupils also. And the total diffractive rings, as I told you earlier, is 4 millimeters, which is a nice, a balance between the two options that we have. And it's a non-oxidized surface. So oxidization definitely has some step pattern on the back surface, which does cause some amount of diffraction and light loss. It's a true hydrophobic lens. Even though it is supplied in a fluid container, it's a true hydrophobic lens with a natural yellow material, which does not block the blue light. Blocking the blue light has some undesirable physiological effect, especially in young patients. So it blocks up to 440 nanometers. So it has its own macular protection without changing the spectrum for the spectral sensitivity. And it's an aspheric lens. Again, the Q value is the most important, is the Q value of each lens. I think for most Indian eyes, 0.2 micron, minus 2.2 micron, which is the Q value, is an ideal for most of the lenses, most of the people who have a basic amount of spherical aberration. And obviously, most people may think that it is from India. It's actually made in Ireland. It's so-called, what patients call it as an imported lens. And these are the specifications in detail about this particular lens. And the range of vision I told you is around 72 centimeters, which is a very good intermediate, and 38, which is near for both reading as well as for gadget usage. And if you see that And even as the pupil size increases, the near and intermediate almost follows a flat curve. That means there is no change in the near or intermediate distance, even as the pupil dilates. And this is a very important thing to see. Like you can see at 0 for the distant vision, it is at the highest. And at the near point around 2.5, it is highest. And you see the curve in between the two. There is no drop between two hills here. That means it's almost a flat line, which indicates that there is a very good uncorrected visual acuity for a range from 35 to almost 90 centimeters, which is an excellent day focus curve with the same energy distribution light here. So let me show you like how this lens actually is being implanted. So it is always given in a fluid container. It is dispensed with a, it is not a preloaded lens. We need to load it in the thing, and it's taken out from the fluid container. And it's a very nice sturdy lens, but at the same time quite flexible. So it needs to be injected, fitted into the cartridge with the viscoelastic, and lock it. And it goes through very easily 2.2. It's a, for all MICS incisions and 2.2 microcoaxial incision, this should be fine. So this is a case in progress where it's being injected under hydroimplantation. It goes into the bag very easily, and it can be well manipulated. So this lens works well with an rexis size of 5 millimeters. And so you can see the rings here. Nice rings. There are almost 12 rings. The center 1.12 clear zone, 4 millimeters of rings, and it's in a 5 millimeter axis. You can see the rings and the lens in place. So we had our initial experience was we did a small study with 20 patients of 20 eyes of 13 patients. Around 7 underwent a bilateral surgery, and mean age was not very high because we could really understand the need. We ruled out the people who are very old age because their visual requirements may be different. So we took patients who are around 50 years with the normal, most of them had normal parameters. And we evaluated for 1 week and 1 month. We evaluated uncorrected and corrected distant, near, and intermediate visual acuity, and the reading speed. The contrast obviously is very important for any trifocal. Reading speed of 40, 60, and 80 centimeters. So this was the result, and uncorrected near visual acuity was N6, which was very important. Even at 60 and 80, we had very encouraging results. What was very important is that almost 90% achieved 6.6 uncorrected and 100% with correction. And almost 100% achieved uncorrected near visual acuity. Whereas the intermediate was quite encouraging and most people were happy. And what is very important that we had was at 40 centimeters, this was reading speed, how many number of words this read per minute, okay, was taken, and you could see that at 40, 60, 80, they're almost comparable. There was never any kind of a lag in the reading speed, and it was almost for all distances. And contrast, actually, of course, after cataracts, the contrast improved, but nobody had any contrast less than 1.5 on the Pelier-Robson chart, and a very good defocus curve. Then with conclusion, patient satisfaction and spectacle independence were almost 100%. There were no major photic phenomena or IOL glistenings, and most patients who had unilateral implant wanted the same IOL in the second eye too. And the take-home message is you have one new option in presbyopia correction in cataract surgery, the trifocal lenses. The Optiflex Trio from Biotech really serves as a good alternative for the present lenses for the patient requirements. And obviously, you need to customize from the patient based on the patient profile and other things. And safe and uneventful surgery always complements this IOL. So thank you very much for the opportunity. I'll stop sharing my screen. Hi, Priyank.
Hi, sir. Good morning, sir. So with your permission, shall I start, sir?
Please.
Right. So good morning, everyone. At the outset, I would thank the team of KOS and Dr. Elan Kumaran for giving us the opportunity, and the biotech team. So today I will be talking about the ICL phakic IOL, its types, and my experience with these lenses. I have no financial interest with them. Basically, just a small history that these phakic IOLs are pretty there from pretty long time. There are 3 types: the angle chamber, the iris fixated and the posterior chambers. Of this, the PIOLs, that's the posterior chamber IOLs, are the ones which are more successful and been there for a long time and give us a better outcomes. So the acrylic IOL range has, it is a lens which is a hydrophilic in nature, where it can be implanted through a 2.8 millimeter incision, and it can be customized to any power, any size based on your measurements. The range comes from -3 to -23 at present, but they are also having a customized range which can be customized for your patient's eye, and it's made from an acrylic material which is for a long-term performance. So basically the indications, it's the same for all phakic IOLs, the age about 18 to 20 or 21 beyond, stable refraction for at least 1 year, no other previous ocular pathology like corneal or intraocular pathologies, those who are not fit for corneal refractive surgeries, and AC depth should be more than 2.8 millimeters, and the endothelial count, if done specular microscopic, should be more than 2000 cells per cubic meter. Now, this is one slide which I would want you to see. I would not go through the whole part of the slide. The 3 points which I would want you to know were the difference of phakic IOLs, LASIK, and PRK. Most of the times, the most favorite procedures are the corneal refractive, like the LASIK or the PRKs. With PRKs, it's becoming more evident now, the surface procedures. But the advantage where the phakic IOLs take is this. It does not, it does not take on the corneal tissue. There is no dry eyes related to these phakic IOLs, and these are 100% reversible. Of course, there might be some tissue damage if not held properly, but most of the times, they do not have any problem. In my experience of what so many months I've been doing of more than 120 plus lenses which I've implanted, there has not been even a single case where I had to explant or redial the lenses. They are very, very stable. The contraindications are similar for all. I don't think so I will have to go through this because it's the same for all phakic IOLs as no. The pre-op assessment is very important for all. In specific for the acrylic IOL, I'll tell that you have to do an objective and subjective acceptance at 12 millimeter vertex distance, which is give you a better outcome. The white ACD, the anterior chamber depth of 2.8 and above, anterior posterior segment examinations. The white to white is more. You have to check both digitally and optically. You will have to check that. That will give you better outcomes. If you're sending a case of a form fracture corrective corneas or a post C3R, what my suggestion is that you do also send a topographic report along with that, and do mention to the engineer that this is a post C3R, a post-operative case, a post-LASIK case. So the R&D team would work on it and give you the best possible outcome for your patient. So the white to white measurement is from mid-limbus to mid-limbus, and it's at the horizontal level. You can either use the calipers, which is an outdated one, which I would say not much of them is used, but the digital caliper, which is much easier and easily available. So the lenses per se, the dimensions of it comes in 4 variants from 12 to 13.5 in 0.5 millimeter variations. The most important thing which they have made a change is this, the central hole. Okay, now this is just 0.36 millimeters. So this does not block so easily, but also it does not cause much of a photic phenomenon. Yes, few patients may complain initial stages for few days to few weeks of a small glare or halos when they see only a direct bright light, like if you see a tube light or a bright light halogen light, then you would see, but in a normal straight conversation or straight view, they will not be able to notice anything, even if you're working on a laptop or a desktop. So these are the details of the thing, but I don't think so. This might be required for you, because if you're looking in a very specific type of lenses for your patient, than this. But one common thing which you should notice, as the power goes higher, okay, the optical zone starts decreasing. So you need to know what is your pupil size when you're trying to match it out. This is what the most important slide, what for us would be, is the ACD in relation to the white to white. Now, when you do a white to white and ACD anti-HM depth and send it to you, you will also have to try to choose which type of lens diameter you want. 99.9% the company will recommend, you just have to go with it. But when there is a small change, I would also recommend you to talk to the team and see what's happening. Because let's say your white to white diameter is 11.20, right? At number 2, if I'm saying here, but your ACD is 3.35. So it comes here. So then you can either choose a 12 also, or 12 this one. So it's a similar thing. But when you go to the next level, if it's there, then it becomes 12.5. So based on your experience, and you can talk to the team of the R&D, they will help you out. They're very, very friendly, and they'll give you a call and send you a mail also regarding the changes. It's very easy to calculate. You can just sit at home or in your office and do the calculation. You can either log on to biotechcalculators.com or download the app for free from Google Play or App Stores. And it just takes about 10 minutes to log in the first time to create your database. And then after it's just done. But what my suggestion is, even if you do this, I would still advise you to talk to the regional manager or who is representative of the company, to talk to them and then get the details so that you don't sometimes miss out any important points. So the implantation of the lens is basically the markings. Now, the phakic IOL of ICRIL from the ICRIL, that's a biotech, has a leading left hole. So this should be on the left side when you're trying to implant. If it's on the right side, on the right view, this is going to be a problem. That means the lens is upside down. So this should be on the left side. So then that's a clear marking saying that you are right on track. So I'll show you a small video of a surgery which I've done, so that you will be able to see how easy it is and how quickly can you implant the lenses. So this is an unedited video which has been taken. So after marking is done on slit lamp, you just make a side port incision. Okay, I generally do a superior one because I'm used to it, but temporal superior incision does not make much difference. You put intracameral lignocaine anesthetic, then put an OVD into the anterior chamber. Then you make your 2.8 incision with the 2.8 keratome. You can make biplanar, that should be fine, or even triplanar, but be careful that you do not go full in and try to touch your anterior lenticular part. Then fill your anterior chamber with the OVD. HPMC is the best. I would recommend HPMC. I'm not a very fan of hyaluronic acid for an phakic IOL. Then a lens which is already loaded, just implant it. And then when I'm trying to implant, I just take a slow step and see that the left implanting haptic has a dialing hole. So that means I'm okay, and this is a rightly placed lens. And slowly inject in phases so that you do not push it very fast. You can put it into the anterior segment and just wait for a few seconds, and it loads. It unfolds. Then with the phakic IOL tucker, you just have to push it in slowly, and easily it goes behind the iris. You don't have to do any major manipulation inside there, because it's a bit firmless compared to the other competitor. The Star is a bit more flexible, but then this is a bit more firm, but the stability of both of them are good, and even this is very, very stable. I have not had even a single case where there was any rotation instability. whatever cases I have done, and it's all been very stable, and they're all bang on target, and no one has had any post-operative surprises till now. I generally use a Simcoe because I feel it's more comfortable in my hands than a coaxial. You just have to do a rock and roll technique in the center of the optic, so that the central hole allows the OVD, which is trapped behind the lens, to be aspirated out from the chamber. And in just about in few seconds, the lens is done, and you just see how even after a bit of manipulation, the lens is still stable. It's not moved out. So the whole thing, the whole surgery, this is an unedited video, mind. So it's about 3.5 minutes or 4 minutes. The surgery is all done. So it's not a difficult one, but the only thing is, in the first few cases, be careful. The engineer or from the company will also be with you to guide you. But then after a few cases, I think the learning curve may not be so difficult. You can do that fast. So these are the acrylic phakic lenses. This is a phakic, this is a spherical IOL, and this one is the toric IOL. Here you can see those marks. So these are toricity. Now the advantage in these lenses, which they have also come out with, is the toricity. Now there are most initially in the olden days, when we used to have from start, we used to rotate the lens to about 45 degrees and 60 degrees. Now they have come up with the toricity at every 30 degrees. So it starts at 0, 30, 60, 90, 120, and 150. So you do not have to rotate a lens more than 15 degrees at any given point of time. Let's say if your axis should have was placement for about 50 degrees. So you do not have to, the company not give you a lens which is for 90 degrees or 180 degrees and rotate for 40 degrees or 50 degrees. It will give you a lens which is, let's say, about 30 degrees and 60 degrees, and will give you to rotate for by 10 degrees. That's it. So it's much easier, and the stability of the lenses are very good. They sit directly in the sulcus. That way. Thank you. At the outset, I would thank Biotech also for the good lens. So, and any doubts or any queries anyone would have regarding Optiflex Trio or phakic acryl IOLs?
Hi, Jagdish. Hi, Savio.
Hello, sir.
We are the audience for your session.
Sir.
Yeah, audience, speakers, all in one.
So Ashwin, can we start off with the next session and introduce Dr. J.K. Reddy? Though he doesn't need any introduction.
Yes.
Really.
So we can start.
So on the outset, I'd like to welcome Dr. J.K. Reddy. And he's somebody who doesn't need an introduction. He's the chief consultant in cornea, refractive, and cataract surgery in the head of Department of Ophthalmology in Sankara, Coimbatore, doing wonderful work. And a CV just came to me, sir, short CV, and really, I would say it is tremendous. You know, done more than 50,000 surgeries and done a lot of contribution in the field of ophthalmology, right, in presentation of research, publication, and education. And without further ado, I'd like to welcome Dr. J.K. Reddy and give his talk on the Indian scenario of CME. And also would like to thank Coscon and Novartis for giving us this opportunity. So over to you, sir.
Thank you, Xavier. And it's my pleasure to be here. And I thank Novartis and the Coscon for giving me this opportunity to talk. Today, my talk is on cystoid macular. Generally, I don't talk on medical things, usually in surgical work, but this is unusual. And it's very interesting for me. That's why I took this particular talk about this molecule. Then coming to CME, it's very less. This is 2% and uncomplicated cataract surgery. Of course, complicated, the incidence goes up, depending upon the complication. The angiographic CME is a bit high, but nowadays, now angiographic is gone. The definition now we are only based on OCT, And most of the places routinely they do OCT postoperatively to look into that, though we are not having statistics. And the another important thing is diabetes. Even without retinopathy, with retinopathy, the CME incidence post-cataract is a bit high. This is a very bad things we never want to see in our life, in our patients, and even uncomplicated surgery. So as far as the significance, incidence, no, it's not highly significant. But in clinical practice, yes, we are very much disturbed, and by this, and patients are disturbed, and it's really disturbed in our practice, having a CME in uncomplicated cataract surgery. So what is the mechanism, pathophysiology? Looking at that, the ultimate is the prostaglandins. Somewhere they get released. From where they get released, that is the biggest question. And they go down and macula, track down and produce a CME in the macula. Nowhere else in the retina, only in the macula where we don't want to see it. So modern cataract surgery is such a clean and such as atraumatic surgery. What is the source of inflammation? It looks like the Nsaids lens epithelial cells, not the intraocular lenses or the surgical trauma or the viscoelastics we use. They are all very high quality nowadays. The lens epithelial cells, which are protected from body, suddenly when they expose to the aqueous, they start irritating. Even aqueous they don't like, so they start producing prostaglandins inflammation, which will last for a few weeks. After that, they keep quiet. So it looks like
Just interrupt you, sir. Your slides have stopped moving, sir.
Okay.
Yeah.
Now?
It's still showing the same slide, sir. Can you make it full screen? Yeah. Now it's working, sir.
Now it's working.
Yes. Thank you, sir.
Now?
Yeah. Working fine, sir.
Yeah, okay. Full screen is not working. It doesn't matter. Sometimes it happens. So where is the risk? The risk, it looks like the diabetic cases and pre-existing ocular condition, intraoperative complication, as we know. And what is our prevention strategy? The prophylaxis, we go for prostaglandin inhibitors, the mainstay. Topical steroids, as usual adjuvants, they don't prevent CME as it is adjuvants, and oral prostaglandin inhibitors and dastazolamide, bit more complicated approach. So when it comes to the Nsaids, the evolution, we have flubrufin starting with, then ketorolac, then diclofenac and bromifenac. Diclofenac disappeared from the market. Right now we got nepafenac and bromifenac, which are more popular. And of course, the new thing in the one is from the Alcan 0.3%, which is Ilvero launched as. So the advantage is very good aqueous penetration and prolonged action, and distribution throughout the ocular tissue is very good for this molecule. And particularly once a day dosing is very attractive, and the bioavailability is very good. This we need to understand that BAK, now a lot of companies are introducing BAK free preparation. The advantage of BAK is penetration of the drug. Once a day BAK is not a big problem, and the penetration of drug is very good when compared with BAK free preparations, which are chemical equivalents, but a bioequivalence is always doubtful about the. Another thing is the prodrug formulation, and it's very good analgesic, gives very good postoperative analgesic effect also. So the dosage is for complicated cases, it goes up to 2 months. For uncomplicated cases, once a day, starting 1 day before surgery to 2 weeks. In complicated cases, we can go up to 60 days, and in diabetes also 40 to 50 days is ideal postoperative period to get very good results. So the other benefits of this is intraoperative mydriasis and postoperative pain control. So where they differ from the steroids routinely we are using, it's in the depth of penetration of topical application. That's very important. We need to understand, and the target tissue and analgesic. Steroids are not analgesic. So the Nsaids are, especially nepafenac 0.3% gives very good analgesic effect, and the mechanism of action is different. They are cyclooxygenase pathway, whereas that is arachidonic acid pathway. So when it comes to the topical steroids, they cannot penetrate beyond ciliary body. They touch the iris, and maximum they can go up to ciliary, not even ciliary body. Whereas nepafenac 0.3%, Ilvero goes up to the macula, reaches all parts of the sclera, and reaches all ocular tissues, intraocular tissues. So where the Nsaids do not work, we need to understand. Pre-existing diabetic macular edema doesn't work, and any macular edema associated with ERM or VMT, these cases, so it doesn't work. There is no point in trying to do that. Use these drops and control these conditions. So what are the side effects? The epithelial toxicity is very important. We need to remember in case of dry eyes, and pingicula and pterygium is there also. We should be a bit careful. We should add a lubricant and a lag ophthalmos, and these 2-3 conditions I stress. And delayed epithelial healing, if there is any epithelial defect like in PRK, all those cases, better not to use it as for pain control. And allergic dermatitis is very, very rare, but we have to look at the lid margins where the drug trickled once in a while, once in 200 patients, you may see allergic dermatitis. So coming to the topical steroids, along with that, is it necessary? I feel it's absolutely necessary to use Nsaids, though incidence is very less. It's so disturbing for the patient surgeon. I feel it is absolutely necessary to control, for control of CME, to use Nsaids along with topical steroids. And in high risk case, especially diabetes, and you have a complicated cataract surgery or a complicated cataract, is up to 2 to 3 months usage gives very good results. So the question is, we have such a nice molecule, 0.3%, very good depth of penetration, going beyond steroids everywhere in the intraocular tissue. Can they replace the steroids? We have, going to the literature, we have very few articles, they are available, which shows that Nsaids alone are as good as steroids, or some reports are showing that the results are a little better than steroids, Nsaids alone. So we took up a study. This study is not a sponsored study. This is an in-house study, and nobody paid for that. So we did around, initially we did 2 years back when the initial molecule was launched, Ilvero, a monotherapy. A patient receives just Ilvero, nothing else. And the other group received a lot with 0.1% epiphenac. And all cases, this is the dosage. As usual, we didn't reduce the time. We went for 45 days tapering dosage of epiphenac 0.3%. 3 times start with, and twice a day and once a day, 10 days tapering, and totally around 45 days. And the other group received for the same duration along with loteprednol. And we did a OCT angio also in these cases. We found the results are both equal. Then, and there's no difference, statistical difference. And then came our answer, yes, this can replace steroids. So from what is the advantage? The less chance of infection, fear is not infection, it's a fear of infection, and less chance of almost glaucoma is a known complication of steroids. So it will, especially in myopes and young and patients and pre-existing glaucoma, and rebound inflammation. When you stop the steroids, so they get used to steroids, you get a rebound in almost from 4 to 5% of cataract patients. This can be totally eliminated, and that's what we call steroid dependence. So this is now my routine schedule for my case for the past 2 years. They just receive a Ilvero 3 times a day. As I'm not using steroids, I don't use antibiotic also in these cases post-operatively, right from day 1. They just receive twice, 3 times a day steroids, very convenient. So, but I'm adding homatropin also twice a day for 10 days. So this is my schedule. Homatropin they get for a week or 10 days, and Ilvero, epiphenac 0.3%, 3 times for 10 days, 2 times twice a day for 15, once a day for 15 days. Very, very convenient for the patient and for the attenders. So it is almost 18 months now. I'm completing 2 years, and more than a few thousand cases we did. And we have not used steroids except very, very few cases where we need to use a preoperative or postoperative complication. What advantages I got? Very less rebound inflammation, almost nil. Simple dosage, very good compliance by the patient. You don't need to worry whether applied or not, just twice a day or thrice a day. And reduce complaints from the patient because it's so convenient. They are immediately willing for the other eye, even without you asking for that. And better confidence both for the surgeon and for the patient. I feel this is the time for change. We need to stop steroids in post-cataract and complicated cases. And that's where I'm going right now for the past 2 years. I thank Novartis and the Cascon team for allowing me to share my experience and a change which I made in the last few years in the management of post-op. Thank you very much.
Thank you so much for a very insightful talk. And leaving steroids is something ophthalmologists really don't want to do in cataract surgery. And one question I would like to ask you is, do you have a pre-operative NSAID regime also, sir?
Right now, no, because most of our patients, they just walk in on the day of surgery. The appointment is not that tightly scheduled. So we are not using only the pre-cataract surgery. They come in the morning, they receive a drop. That's all. Both, they don't receive anything, including antibiotics, nothing. They don't receive anything. On the day of surgery, when they come, walk into the hospital, then they get both antibiotics and Nsaids before cataract surgery.
And sir, do you make any modifications in your timetable regimen in patients who are diabetic or patients who have DME, or if it's a complicated surgery?
Complicated surgery, yes, depending upon the one, we decide if there is a small PCR, no vitreous disturbance, nothing, I don't change. If there is a vitreous disturbance, something like that, then we add, right now we are adding steroids also for them. And there is a pre-existing DME with a good visual potential, and retina people do not advise any further treatment. 2 months we are giving Nsaids once a day. That's the only.
Thank you so much, sir. Thank you so much for very insightful talk and sharing your vast experience with us. And I hope we can always shift over to steroid-free surgery.
Thank you very much.
So we'd like to thank Coscon again and Novartis for giving us this opportunity. It's a tight schedule and we're told to stick to time, and we have gladly done so. So
Yeah.
all over back to Coscon. Thank you so much, sir, for your valuable time and sharing your experience.
Thanks, Sevio, and thanks, Dr. J.K. Reddy. It's my pleasure now to introduce Dr. Sachin. Before that, I would like to thank Novartis and Coscon for giving us this platform for this wonderful session. Well, Dr. Sachin Dharwarkar is founder director of Samantha Clinics and also director glaucoma services at Aditya Jyot Eye Hospital. Quite a dynamic personality, visits a number of hospitals as a visiting consultant and honorary consultant. And he's done a lot of work on imaging, OCT, stereo photography. So it would be interesting to hear him. He has multiple presentations and publications to his credit. So I give the platform to Dr. Sachin Dharwarkar now. Dr. Sachin, please.
Yeah. Morning, everybody, and a big thank you to Novartis and Karnataka Society for having me here, and Dr. Sushma for that kind introduction. Are my slides seen?
Not yet, Sachin.
Just a minute. Share screen. Is it seen now?
Yeah, now we can see your slides.
Okay, so we are here to discuss. Yeah, is it seen now?
Yeah, it is seen, but not in the slideshow mode. Yeah, that's fine. Can go ahead.
So we are here to discuss about the new molecule that has been launched by Novartis, that is Azarga. New to India, though it's been there for more than a decade in the Western world, and with pretty good outcomes. So let us see where we can place this in our current day practice and adopt this for our normal day-to-day usage. So we see these kind of patients, these are a commonplace in glaucoma therapy, and with these kind of irritating side effects, do we expect them to continue their medications is the question. And if we were in their place, definitely not. We would need medications which affect our lifestyle and quality of life much less than all this. So from 2013 to 2020, all the medication decisions were guided by this one single paper, which implicated benzalkonium chloride as the only mother of all worries. But if we see, each individual drug has its own set of side effects, that is prostaglandin analogs of hyperemia or orbitopathy. Alpha agonists have hyperemia and follicular conjunctivitis. Carbonic anhydrase have punctate erosions, and ROCK inhibitors do have acute hyperemia and endothelial side effects. Now, the only two classes of drugs that are relatively naive to develop side effects are timolol, maleate, brinzolamide, and to a certain extent latanoprost. But these side effects are inherent to the medication itself, in addition to the ones for BAK. So BAK alone is not the culprit, but the medications have their own set of problems. So when we are talking about the effects on quality of life, these do affect the adherence and persistence, and ultimately whether the patient will take the medication or not. So it's very important for us to address these two issues if we sincerely feel that our patients will continue the therapy for his entire lifetime or the time till which you tell him to. So the adherence and the persistence, which dictate whether a person behaves exactly according to what you have told and continues the treatment with the prescribed medications for a specific length of time, will be dictated on the effect on his quality of life. So medicines cannot be effective in patients who do not take them. So we have to make sure that we make them comfortable and give them a side effect profile such that they'll continue their medication. Also remember that for each and every patient, you have different sets of quality of life indicators. And so it's very important consideration. A loss of quality of life perception would be different for different individuals. So we should be very specific when we are dealing with these patients and be careful so that they do not take their medications. As far as studies on adherence to medications are concerned, this was observed to be a very, very important factor. And if you see, medication related side effects led to around 32% discontinuation of medical therapy. So we have to be very, very careful in minimizing the side effects in our treatment regimen. As far as other antecedents of adherence are concerned, many patients of those who cited adherence blockages, most of the patients cited pain and discomfort to the medication as one of the important causes in a few studies that have been done. And these are definitely related to the patient therapy for the long term. So whenever there is a new launch or a new molecule, what exactly should we look at in terms of the strength and the weaknesses, so that we can incorporate the molecules in our clinical practice? So always you have to see for the history and the track record of the molecule, the evidence that is available and the data that is available on file, manufacturing processes, QCs and pharmaceutics, whether we are convinced that they have the minimal side effect profile and deliver the desired concentration of the drug on the ocular surface, and what is the indication of such molecules in the current scenario. So that is all these things we consider before incorporating them into our clinical practice. So we shall see these few points in the next few minutes. So always remember that innovative products have certain advantages. They have a proven track record. As we know that Azarga has been there in the market since 2008, and now it is around 2021. So we have around 13 years of post-marketing experience besides being the innovator molecule. So let us see what data is there on file to help us make a decision in using this molecule. So we have clinical trials, we have formulations, manufacturing process and audits that have taken place. And many studies have been done using this molecule, particularly this molecule, as the central molecule for the study. So this is a fixed dose combination, as we know. So what is the rationale of using a fixed dose combination in practice? Not as a first line therapy, but definitely as we go on adding more and more molecules, FDCs become very, very important in reducing the number of drugs. So as we know, for the adherence, it is important that we have lesser number of medications going into the eye. What it does is reduces the preservative load and also reduces the number of drops per day. In each of those cases, definitely it helps us in increasing the compliance, adherence and persistence of the patient and reduction of the side effects. So about this particular molecule, what is the literature and the clinical evidence that is available with us? So we definitely know that when you have to improve the compliance and adherence, we have to go in for a fixed dose combination. So if you have then or you can definitely combine 2 drugs in 2 bottles. So because of which the number of total instillations will come down to 5 drops instead of the 7 which we had previously. So definitely using a fixed combination or unfixed will be better, and that limits the exposure of preservatives also. Also, you have to remember that you have to use a formulation which is a pH which is near the tear film, because that will reduce the post-installation irritation and definitely which is a niggling point in terms of continuation of the medicines. Also, an approach to improve treatment outcomes, this fixed dose combination definitely increases the efficacy and has efficacy over the unfixed combination in terms of the pressure lowering effect, and they are considered again important for medication adherence, as we have just seen. Now, when we start, the studies were done for effect of brinzolamide and timolol molecule over brinzolamide and timolol individually. When this molecule was launched, that is a proof of concept of this molecule of fixed dose combination was obtained in 2008. It has been categorically proven that the use of brinzolamide timolol combination has been equivalent or superior in low IOP lowering as compared to brinzolamide timolol alone. So the proof of concept has been there. It has been established in many studies till date. This is just one of the prototypical study where we have around 30 to 30%, 34% lowering of IOP with this fixed dose combination. Now, as we know, whatever the available fixed dose combinations are there for glaucoma management, we have a beta blocker involving fixed dose combination or beta blocker free. So this particular molecule comes in the beta blocker fixed dose combination, that is brinzolamide and timolol, that is Azarga here. So how do we select the right fixed dose combination for glaucoma management? So what happens is if we put all the FDCs with timolol that are available together, we have a brimonidine based fixed dose combination and a dorzolamide timolol or brinzolamide timolol based fixed dose combinations. Brinzolamide and brimonidine, let us keep it at the side for the time being for the difference in the side effect profile. So if we have, for example, a patient on 3 medications with discomfort and minimal side effects, and if we have 3 molecules to combine, that is travoprost, timolol, and dorzolamide or brimonidine, then the available dorzolamide, brinzolamide, or brimonidine, then the available combinations are the ones which are given below. So if we go for the side effect profile, we definitely know the side effect profile of brimonidine in terms of allergic conjunctivitis is higher, definitely higher than that of dorzolamide or brinzolamide timolol. And the side effects of brinzolamide timolol are definitely slightly lesser than dorzolamide timolol. Now, if we combine these 3 drugs, the ideal way to combine these would definitely be back-free travoprost with a brinzolamide timolol combination because of the lower stinging and the lower side effects. Now, all this is true provided we meet the target pressures with this particular combination. Just in case we need a notch higher, we may need to shift to a different combination. But in terms of longevity and side effect profile, this definitely will win the race. Now, as far as combinations of BTFC and DTFC is concerned, that is dorzolamide timolol and brinzolamide timolol combination, this is definitely a gray zone. There are multiple conflicting reports in literature, but by and large, even if there is a difference, it's very minuscule. So by and large, parallel. So having an equivalent effect or near equivalent effect, we will definitely go for a combination with a lesser amount of side effects. So again, as I told you, our bottom line will be meeting of the target pressure requirements. If it is meeting both the combinations meet the target pressure requirements, definitely brinzolamide timolol will be much better tolerated than dorzolamide timolol. And obviously, when we see the literatures which combine or which compare and contrast, we should also know what kind of study methodology was used and number of eyes, so that those will definitely give more robustness of the data that we are looking at. Also, the nocturnal control with brimonidine and timolol fixed dose combination as an adjunctive to travoprost and brinzolamide timolol combination had been studied, and the nocturnal pressure lowering capacity of brinzolamide timolol was noted to be better in combination with travoprost than dorzolamide timolol, than brimonidine timolol combination. So this also gives us an advantage at nighttime IOP control. Even comparing brinzolamide timolol to dorzolamide timolol over the side effect profile, as we have already seen, because of the pH, the discomfort immediately post instillation, there was a stronger patient preference for brinzolamide timolol as compared to dorzolamide timolol in terms of the immediate post instillation comfort levels. But again, as I told you, bottom line is the comparison is valid if there is a target IOP being made by both molecules. Also, you have to keep a small note of the manufacturing process and the pharmaceutics. In brinzolamide timolol fixed dose combination, right now that is available, that is the Azarga. We do have different kind of excipients which are not available in the conventional brinzolamide timolol, and these are very, very important as far as the viscosity, the drug distribution over the ocular surface, the longevity of the residence in the tear film, and the bioavailability is concerned. So there is a small thought that goes into it, because unnecessarily addition of 7 to 8 molecules is not without any reason. So you have to spare a thought for that. Definitely it affects the physical properties of the solution, as we definitely see here. We are having a more uniform distribution in solution with a greater viscosity as compared to the other molecules where we can have a variable particle size and irregular distribution. So non-API agents are very, very important, and these are the usually the advantages in the innovator molecules as compared to the non-innovator molecules. So having considered this, what I feel should be the indications of these molecules in current practices. Post-operative in cases of drainage implants, management of tenonsis, because we need a non-inflammatory molecule at the end of the surgery to prevent fibrosis in glaucoma surgery. In uveitis and ocular hypertension, it is safe because it doesn't have iatrogenic effects on uveitis like brimonidine might have in one or cases. Chronic post-cataract surgical inflammation with ocular hypertension, which needs 2 drugs, maybe a pressure spike of 30 plus, you can definitely use that as a measure in the interim. Mitigation of side effects in case of maximum medical therapy as a switch to dorzolamide timolol, just in case the patient has an ocular surface problem, punctate epithelial erosions and irritation, which will be taken care of by using a more neutral pH drug, and also a switch in case of corneal side effects. That's what we just discussed. So although we know all this, the caveat is the most reliable scientific evidence is what one sees in your own clinic, in your own hands. So do try the molecule, and if there is a noticeable difference, definitely you will be happy with using it in clinical practice. Thank you.
Well, thanks, Sachin, for taking us through the indications of using a brinzolamide timolol combination and showing us the comparison as you have with the dorzolamide and brinzolamide. I think one question that I would ask you is that how about its usage in children?
Always the data available in children in terms of the carbonic anhydrase inhibitors has always been not so unfavorable as compared to the other molecules. So given a choice, maybe the safest molecules to use in children would be either a dorzolamide or a timolol 0.25%. That's our conventional logic, and I would stand with that still. As far as my usage of brinzolamide and timolol is concerned, it's not been too much in children as of today, because the molecule also has been available recently. But definitely, in terms of the blanket group of carbonic anhydrase inhibitors, it should not be much of an issue. Anyways, in pediatric eyes, we know that all these are stopgap measures and would not be a long-term solution, because most of the glaucomas in children are surgical in nature. But definitely it can be used as a stopgap. Only issue is that in very small children, because the combination is having 0.5 timolol, maybe we would have to be slightly wary of using.
Yeah, true that. I think barring neonates or very young children, it is a useful alternative to dorzolamide timolol combination sometimes, because it avoids that stinging sensation. So, well, thanks, Sachin. I think the next group is already ready, the Dr. Naresh and Rajesh. So we have to hand over. Thanks for taking us through the brinzolamide and timolol.
Thank you so much.
Thank you.
I think we are finished on time also.
Yeah, over to you, Naresh. Yeah, thanks.
Yeah, thanks.
Good morning, sir.
Yeah, morning. Can we start?
Yes, sir. Absolutely.
Okay. So the next topic is breaking common dilemmas in DME management. And we have Dr. Rajesh here. Dr. Rajesh is a consultant at Shankara Eye Hospital, Bangalore. And he has done his MD from the prestigious AIMS, Delhi. And he has over 35 publications. And he has authored many chapters in various textbooks. So I invite Dr. Rajesh to give his talk.
Thanks for that introduction, sir. Much. Video. Can you play the video, please? Hello, everyone. I would like to take this opportunity to thank COSCON and Novartis for giving this platform to speak on breaking common dilemmas in DME management. This is Dr. Rajesh. I'm a consultant VR and ocular oncology at Shankara Eye Hospital, Bangalore. Though this is a Novartis sponsored talk, the slides have been prepared by myself. This is more of my journey, what I read and learned from residency to consultancy. One of the most common presentation is a patient who presents to our OPD with a central involving diabetic macular edema like these patients. Treating these patients were much easier then, because we had only one option of doing laser and it did respond good. What prompted us to follow this treatment protocol was because of the extensive study by EDTRS, which went on for nearly 2 decades and involved 3,700 patients, and they gave us that macular photocoagulation was effective in reducing vision loss because of clinically significant macular edema. So the question is, what changed our mindset in treating these patients in this manner was, what we gave to our patient was just stabilization, that is reduced risk of moderate vision loss by just 50%. It was effective in preserving vision. It was less successful in restoring it once it was lost. Some patients worsened despite the laser because of the scar expansion and subretinal gliosis. So vision improved only in 3% of these patients. What both the patients and the physicians wanted was to look beyond the EDTRS to see if visual gain can be achieved while treating these patients. In 2004, till which the laser was considered as a gold standard, IVTA paved its way into the intravitreal injections. So what was considered as the gold standard laser was demoted, and anti-VEGF paved the way into treatment of the central involving macular. The agenda for today is to touch upon certain dilemmas which are involved in treating diabetic macular edema and to see what the current literature says about. So dilemma number 1 is, how do we presently classify diabetic macular edema? This includes dividing into whether the patient has macular edema or not, and if it present, whether it's a central involving, which is considered as severe, or versus non-central involving, which is moderate and mild. So patients most benefiting from anti-VEGFs are those who have central involving macular edema. So when we look into the management options which are present for CIDME, we have 3 more most important ones. That's the laser, anti-VEGF and steroids. Now with these current studies which have shown that laser alone is far inferior as compared to the anti-VEGF injections, so we are left out with 2 options that include anti-VEGF. So why we have arrived at this conclusion is because of the wealth of evidence that's provided because of the RCTs, which involves ranibizumab, which includes RISE, RIDE, Protocol I, RESTORE, RETAIN, REVEAL and REFINE. All have shown that ranibizumab is far superior as compared to sham in either rapidly gaining vision or sustaining it over a period of time. So early visual acuity gain was maintained up till year 5. We can see that Protocol I showed approximately about 10 letter gain over a period of 5 years. It was not only the vision gain which surprised the clinicians, but even the number of injections which were required to maintain it. Though it was at around 7 to 9 in the first year, over a period of 2 to 3 years it's declined to achieve approximately about 1 to 2 injections in 4th and 5th year. So the next important question which comes into our mind is whether these studies are reproducible only with ranibizumab. When we look into the literature, there are other studies, for example, BOLD, which tested bevacizumab, Pan American Retinal Group, which again tested bevacizumab, and BIVODEX, which looked into steroids and said that they were not inferior to bevacizumab. So all these studies again showed that visual gains were sustained over a period of time with reduced injection, and laser was not supradditive. So the story still now was laser, which was considered as the gold standard, was replaced by anti-VEGF. Anti-VEGF monotherapy is the new gold standard as of now. Additional laser was not truly additive, and vision stabilization has been upgraded to visual improvement. Let us address the other dilemmas commonly seen. As far as the presently available anti-VEGF is concerned, we have 3 main, which include Lucentis, Avastin and aflibercept. So the dilemma is which anti-VEGF to choose. Are all the 3 injections of similar action? So the big fight started by the Protocol T. The DRCR net showed that at 1 year results, if at all a patient has a vision which is between 6 by 9.25 to 612, all the 3 injections fared the same. But if the initial vision loss was more than 6 by 15, then Eylea was better than Lucentis, which was better than Avastin. So majority of a patient fits into the second criterion. So visual acuity in Eylea was 4 lines as compared to Lucentis, which was 3, and Avastin, which was 2.5. Swelling reduction was far superior in Eylea, and both of them was better than Avastin. Laser requirement was about 36% in Eylea versus 46% in Lucentis and 56% in Avastin. So let us look into the 5 years of completion of this Protocol T. At the end of 5 years, we can see that the patients who had initial poor vision at baseline and showed a significant improvement with aflibercept, at the end of conclusion of 5 years, there was hardly any difference between aflibercept and ranibizumab. So now that we have established that anti-VEGF is the way to go about treating these patients, so is it that we keep giving anti-VEGF to these patients? So let us look into the untold story of Protocol T. So when we looked at all the eligible patients who were, had completed 5 years of follow-up, when we looked at the visual acuity, though at 5 years it was much better the baseline, but when we looked at the 2 years follow-up, there was an average reduction of 5 letters. The central macular thickness was almost similar between 2 years and 5 years. Then what was the reason for the mean visual acuity to have worsened? Maybe it might be ganglion cell death, which was due to the lack of VEGF, which was completely suppressed by the anti-VEGF injection, which was given very aggressively. Most of these patients had in real world switched injections between one to the other. So it was not only ranibizumab which was keeping the vision intact. It's probably impossible to replicate the studies in real world scenarios. The next common dilemma is, do we look into the innovator or a biosimilar ranibizumab? As far as today is concerned, if you look into the literature, there is numerous number of studies regarding the innovator ranibizumab as versus very minimal amount of data which is available to the biosimilar. Since the safety of the patient is of concern, so obviously the innovator ranibizumab gains an upper hand. So let us look into the third and the final of the dilemmas. So are there any suboptimal responders to the DME? So when we look into the DRCR net protocol I, we realized that about 40% of the patients by the end of 3 years showed persistence of diabetic macular edema, which can be classified as chronic. This amounted to nearly 16% of the overall patients which were treated. So the next important question is, what do we treat these chronic persistent DME patients with? Do we switch between the injections? When you look into the DRCR net trial again, so if at all we continued the injection from 3 months to 6 months, then 3 to 5 letter improvement in the mean visual acuity was noted at 3 years, although continued with the initial agent, and 40 to 70 microns of reduction in the central macular thickness was noted. To summarize, the diabetic is a growing wide epidemic. The rapid clinical outcomes of ranibizumab is sustained up to 5 years as seen in clinical studies. Innovator ranibizumab is better as compared to the biosimilars. The addition of steroid to ranibizumab did not offer much additional clinical value as far as studies are concerned, and suboptimal responders can be delayed responders who need more time to respond to the anti-VEGF. So looking at all this, is it treating DME so easy? Let us look into the drawbacks of it, the cost. So what all the studies have shown that you keep continuously injecting these patients, but let us look into the cost of it. Second one is, there are certain patients whose visual acuity, despite giving monthly anti-VEGF, were not replaceable in real world scenario. Let us look the pooled data of RISE and RIGHT trial, which showed that only 40% of the patients could meet the criteria of gaining vision of more than 3 lines at the end of 100 weeks. And real world scenario, in USA, 75% of the patients received less than 3 injections in their first year of beginning the treatment. So compliance and comprehension of treatment is one of the biggest challenges in developing nations like India. So to conclude, treating patients in clinical trials and real world scenarios are totally different. So let us look at what are the characteristics of clinical trials. They are limited by eligibility criteria. They have a specific design study. But these design studies mainly address metrics of efficacy and potential safety events that occur at very high frequency. They neglect the others. So there is a strict adherence to the protocol, which is very mandatory. What are the challenges faced at the introduction into clinical practice are, so there is a wider population excluded from the clinical trials. So the treatment continuation in the longer term, the quality of life issues, compliance issues, because it's not only the patient, the relatives, everybody have to accompany them. So there's a loss of livelihood and man-hours spent in getting these treatment. Understanding outcomes in the presence of lack of adherence to protocol is totally different. Burden on the treatment for patient caregivers and providers is beyond words. Thank you for the patient hearing.
Yeah. Thanks, Dr. Rajesh, for a very concise and sort of up-to-date talk. Just for the benefit of the listeners, so I'll just ask a few basic sort of questions or your guidelines, what you follow. When do you label a patient as a non-responder? So is it after 3 injections or after 5, 6, or because some patients may respond a little late? So what do you follow?
That's what the studies have shown, but most of my patients are not on that, financially sound to go on with a single injection for 6 weeks, 6 injections in a row. So max to max, I give about 2 injections. If it's not responding because of the financial constraints, I do switch between agents or go into a steroid agent if they're not responded to anti-VEGF, rather than switching between the classes itself. But if the patient is ready to try, yes, as they have clearly showed that 6 months they do respond. So it's less than about 6% of the patients who don't respond even at 6 injections. So that's a very merge number. So we can do try if the patient is willing to go ahead with these injections. So what about you, sir? How would you?
I agree. See, in Indian scenario, it's really difficult to convince the patient to take 6 injections if you don't really see early response.
Early response.
Yeah, and I think studies have also shown that I think 3 injections give a good idea about the long-term efficacy.
Efficacy. And
Yeah.
even in fact, there is an IJO article by Dr. Lalit Verma who says that the first injection itself will tell us if the first injection, the response is good, definitely they keep on responding, way beyond. But if it's not responded, then the average of responding is very, very less. The first injection itself, that's what he has told. And yes, 3 injections would be a fair, game to ask the patient to continue. And if it doesn't respond, then switch it. Totally agree.
And any role of laser in center-involved macular edema?
So basically, to tell you very frankly, I do laser, prompt laser itself. I do give injection, and post-injection, once the edema is completely subsided, I usually review the patient at around 1 to 2 weeks and see if there's any large, something a little bit more than microenzymes, which are a little bit far away from the fovea, and if possible, target them and treat. I usually use the subthreshold laser to make sure that I'm not causing too much of harm into that macular area, and it's yellow laser, so in that way preserving the pigment also. Yes, I do laser in lot more patients.
So
monotherapy as such is very minimal, sir.
Is this laser based on the FFA or just on the clinical?
FFA, sir. The first, the naive patient, or whenever the patient comes to me on the first time, I do an FFA. So to make sure, what we are dealing with, how much is the ischemia. And I do Octa also in supplementation to FFA, because I've not completely switched my practice into Octa per se, because edema can have some kind of a lacunae which may show as ischemic areas, but it may not be so. So I'm doing both FFA and Octa to see if there's any visual issues because of non-perfusion, and the leakage areas, mark them, give the injection, and after that treat them. Yes.
Yeah, but this is your personal sort of way of managing. You don't have any randomized trial to really say this works.
Absolutely, sir. No, this because it's working and the patient receives a minimal number of injections and they do well. So I continue to practice the same lines. But as been universally recorded, monotherapy with anti-VEGF and given over a period of time without any laser or deferred laser, it's as good as doing laser, because lasering at the central fovea, and especially in the younger generation, they're not much confident doing focal lasers. So that's what I've seen, and that might harm. Rather than that, better to give anti-VEGFs and keep the vision abreast.
And do you use steroid as a primary or the first line treatment in any case, or you always go with anti-VEGF first?
So pseudophakic patients, my first preference is now steroid agents, implants, to be very precise.
So that will depend upon the pattern of the edema or just the convenience of the patient?
Convenience of the patient, and since I don't have to worry about the cataract as a side effect because of the implants. And rarely I've seen patients developing cataract before the second injection. So 2 injections they can tolerate even in younger age group if we give. But since anti-VEGF, no hassle. No need to think about these complications. I do prefer in younger age patients anti-VEGF itself. In older age patients or in cardiac comorbidities, I would like to go ahead with steroid implants.
And the pattern of the edema sort of helps you in choosing the anti-VEGF, or the studies are not really very clear about this sort of approach?
So we did look into through 3 or 4 OCT biomarkers. One is, as you rightly pointed out, subretinal fluid or intraretinal fluid, or hyperreflective dots. All these, we did look into these factors. Nothing really showcased that if one agent is better than the other in dealing with certain specific fluid, whether it's compartmentalized in the intraretinal or subretinal space. A small cohort of patients, about 25 to 30, which we promptly followed up from the day of injection and through about 6 months, showed that if the patient had some hyperreflective dots, they responded much better and retained for a longer period of time when we gave steroids as compared to anti-VEGF. But these are controversial because some people say that anti-VEGF is better, some people say it's steroid. Now, some people, there is evolving theory about it's not only inflammatory, something else which is doing it. With unknown factors like these ganglion cell deaths, which are occurring because of intensive anti-VEGF therapy, maybe switching or intermittent use of steroids would also be a thoughtful process in due course of time. Though there is no rationale for what I'm talking about, other than a theoretical risk that ganglion cell death might occur. This has been seen even in protocol S, where the PDR patients were treated initially with anti-VEGF as compared to laser, and they followed up 5 years. There was some reason of vision loss in these patients. The field loss was also almost similar to the PRP group. So they most probably they're hinting at that there is some amount of ganglion cell death which occurs because of the lack of VEGF factors due to active suppression.
Yeah, so basically, I think still there's a lot of learning that we really need. So the best thing is to, I think whenever we come across a patient who has DME, to counsel the patient properly that it's a chronic problem, multiple injections will be required. Because if the patient goes away with a feeling that 1 or 2 injection is the solution, then he's going to be really upset and he will go on sort of doctor hopping. So better to make it very clear that it's a chronic problem. And one good thing is that with time, as the years go by, the number of injections could come down.
And the second part is there was a huge transition between maintaining vision to now increasing vision, and maybe in another decade or so we might come to an injection or so which we can place or something, reservoirs or something like that, which can maintain the vision, improve eyes, and reverse the diabetic retinopathy process. That would be the way to go about it.
Okay, how much do we have? Some time, or we are supposed to? Because I don't see any.
Sorry, Madam should say. Madam is also has already logged in, so she has to tell us. 24 was what, sir? 24 or 25?
20. It's already 24. So should we?
Yes. Anybody else? Chaita, madam. 25. Yes, I think we are in time, just in time.
Okay, I think so. If there's nothing else, Dr. Rajesh, again, thanks for the nice talk.
Sir.
Yeah. Okay then. Yeah. Bye.
Thank you, sir. Thank you. Bye, sir.
The next session is only starting at 11:30, sir. You have 5 minutes of discussion. I don't know.
Okay, madam, you can enlighten us a little bit.
I don't know what you're actually. I wasn't there in the session. I just joined. What were you all talking about, Rajesh?
We're just talking about certain common dilemmas which we have in treating a patient with CIDME. So the basic 3 questions which I addressed was whether we give anti-VEGF, or which should we keep on giving anti-VEGF, which anti-VEGF to be given, and is there suboptimal response, and what if a patient turns out to be suboptimal, whether we give 3 injections or 6 injections, switch between agents. So that's what I touched upon.
I think we could just could just talk about the systemic investigations, parameters also, because that also is important. So it's not that we just keep giving injections and really don't look at the systemic issues. There could be associated problems like anemia. Such issues also have to be tackled. And if there's a presence of subretinal fluid, so then we need to look at the sort of renal parameters also closely. It's not like AMD. We should remember that it's not emergency. Nothing is going to happen if you wait for a month or so. And in the meantime, you can stress the importance. And the other thing is, if the patient comes with 200, 250, 10 glycoside hemoglobin, and if you keep giving injections, the patient is not going to realize the importance of good control.
Importance of systemic control.
Yeah, so it's better that you don't give injection at 1 month and tell him that you come with a better control, then I'll give the injection. So he learns about the gravity also, and there's a likelihood Otherwise, he'll say anyway, treatment is injections, so
Anyway, it's same
whether it's
injection.
controlled or
Absolutely,
not.
sir.
So I think that has to be stressed.
Absolutely, totally agree, sir. And a few other investigations which we added upon realizing some patients were some bouncers in a clinical practice was one, like since we look into oncology also, there were other patients which had CML and others presenting with a similar kind of complaints. Recently, we have published that also like thrombocytopenia. That's also as an important bearing. Patients have diabetic retinopathy and they come with a huge amount of edema. They don't respond. And we have seen some patients, if the thrombocyte of ITP patients where the platelet count differed, the edema also differed in the same way, even despite not touching these patients. So an hemogram also makes a very, very important role in our investigation.
Yes,
A few handful, yes, sir. A few handful of patients had the sleep apneic syndrome. Even those patients didn't really respond to the treatment that we had given. So getting, if at all, you have tried out all the the investigations and ruled out possible reasons why they are not responding, doing a sleep apneic syndrome study also would help us in getting to a.
I had one patient, and I think Dr. Ramesh also had. Somehow they did not really respond to the treatment for sleep apnea also.
Okay, sir.
So I think we need larger number of cases to really. Theoretically, it looks very nice. It just falls into the picture, but practically, how much really it's going to help? It is just one of the issues that has to be looked into.
Yes, one of the other reasons. The other issue which I looked at, about 6 patients in which we had the sleep apneic. About 4 of them didn't really, could put that CPAP and sleep. They were totally disturbed, so they didn't do it perfectly. And they got adjusted. After about 6 months, there was some amount of change in the CMT for a period of time. So the first initial 4 or 5 months, absolutely not much of change, despite diagnosing them and asking them to take treatment. So that might be also because it's very cumbersome to have a good night's sleep with a CPAP machine onto your face hanging around.
And do you treat and extend in DME, or it is just for AMD patients? It is.
I personally don't practice, sir. I don't personally practice.
Chaitra, you want to add something? Is it there or?
Madam will have lots of things, but time will be a constraint. But whatever she can enlighten us.
I think I agree with whatever you all said. Not much to add, but I think yesterday we had another session on DME where we discussed as to how just with our systemic control, so many times the edema goes away. We may not have intended it to happen, but most often the patient is not under systemic control. And by the time we advise injection and ask the patient to come back after systemic control, it's already the edema is gone. So I think that's a perfect situation for us, but then it doesn't happen all the time. So yes, systemic factors do play a huge role, and I think we should consider that as the first line for at least mild CIDME also. It doesn't have to be aggressive with as far as management goes, pharmacotherapy goes.
Even if not in the initial, I've seen most of the patients who took it to the heart and started controlling, responded beautifully and remained dry for several years together. Patients who were not very keen about that, they keep coming, even though responded about 3 months or 6 months once they need an injection, because there is some amount of EVA in the systemic factors and they come back with the edema.
I think there are some other issues that come into play. I remember distinctly a couple of patients who I got tired of giving injections. The patient also got tired.
Okay,
and suddenly they get lost for 6 months, 1 year. They come with the.
They come back.
Yeah, it was totally gone. I don't know what has happened. So whether the systemic issues got better or the multiple injections have altered the natural history of the disease as such. Suddenly, so you'll be surprised that they don't need any more injections.
But
they all have received a couple of steroids. Yeah, a couple of steroids they have received and antibiotics. Then suddenly they become okay.
Totally. Yeah. We had a few bouncer patients who didn't respond to anything, persistent edema, and we tried some off-label use, like we had exposure to sun. Now we are trying to formalize it. Photobiomodulation. Patient had very good response in that. I personally did some patients with a localized sursnate kind of retinopathy where I did TTT. and the response was also very beautiful. I'm trying to get a publication out of it. We'll share it. So, but these are all, end of the results. We don't have any other burnt out macular edema. There's nothing else to try. So only those.
But somehow I'm not really convinced that laser has no role to play. I think we need some more collaborative and larger studies to really.
True, sir.
Because it makes sense, no?
Yeah, absolutely.
How
Otherwise, most of these patients will go
I can't understand.
Most of these patients will go into bankruptcy, sir, if not. Thanks a lot, sir. Thanks a lot.
Okay.
Thanks, madam, for the insight. Bye, sir. Bye, sir.
Bye.
Thank you.
Thank you.
Hello. Hello. Sir, can I play next video? Dr. Chaitra Jadhav.
1 minute. I think this is a Novartis program. Dr. Chaitra, are you there?
So I'm there, sir.
Dr. Guru Prasad here. Yeah, I need to do a little formality. Okay, that is Chaitra. Oh my God.
Can't recognize me. I'm sorry. I'm at a wedding.
Oh, all right. So multitasking even at the wedding. Only you can do it. Okay. So are you ready, Chaitra?
Yes, I'm here.
And I just see Sachin checking in. So
I will put on my video for a bit and then take it off, sir.
Yeah.
Yeah.
No problem. Yeah.
Hi, Sachin.
No. Let the audience have the advantage of seeing you. You're looking very pretty. Yeah. So.
Sir, can I start a video?
One second. Hold on. Let's start the session and then you can play the video.
Yeah. So we are starting a session on neovascular AMD. Which has in particular evolved over the years, and from no treatment to today's anti-VEGFs, traveling across various treatment modalities like laser, TDT, TTT, vertiporphyrin PDT, and all. There has been a revolutionary change in the the treatment modalities that have happened in the last 20 years. So most of the decision taking is in the management of AMD is based on OCT imaging, and what in the OCT is significant, what is not, is important to know, and we will discuss this today. And we have two eminent speakers. One is Dr. Chaitra Jaydev, whom everyone knows, presently consultant Vitreoretina Services, Narayan Nethralaya Institute, Bangalore, who had a brilliant academic record and fellowship in Vitreoretina from, I think, Minto and also at several other places. She has done her FICO and has a PhD in the impact of imaging the pediatric retina. She has several publications to credit, close to 100. She's been a member of various, she's been an office bearer of various associations and committees. And someone I know since more than a decade, a brilliant and talented retina specialist and researcher, very affable, modest at the same time, and always a pleasure to hear her speak. So with this, I present Dr. Chaitra Jaydev, and she'll be speaking to us on fluid. Dr. Chaitra, please.
You're muted.
Yeah, thank you so much, sir, for that kind introduction. And I have known sir for the last 10 years, and I must say the admiration is mutual. I love him for his humility and the amount of knowledge that he has to impart to all of us. We continue to learn from you, sir. I think you can play our video now. Thank you.
Abhinava can play. Yes.
Today, I'll be talking about demystifying fluid, especially as seen in AMD. Now, I will be covering this talk in the following headings. We'll talk about prevalence, we'll talk about fluid analysis, and also a couple of case examples. We do know that there is an increasing prevalence of AMD with substantial burden. Globally we are seeing it, but more importantly, if you look at Asia itself, there's a very, very steep rise in the number of patients who are now being diagnosed and who require treatment for AMD itself. The global prevalence is predicted to reach close to 300 million by 2040. And when you look at India itself, there are not too many studies, but the prevalence is anywhere between 4 to 12%. Now, the burden on the healthcare system is multifactorial. Declining vision, treatment choices, monitoring needs are very frequent and they can be expensive. The treatment regimens are many, they're expensive and sometimes very confusing to the patient.
Drug cost, of course, is a major concern for most of the patients. Increasing prevalence we're seeing now with longer health span and also because of better healthcare. Now, when you look at a patient's perspective, the frequent treatment and monitoring required, places a very heavy burden on them. They need to come with an attender, they need to travel far distances, and they need to travel frequently and sometimes even monthly. So these are some of the main reasons why I think even a lot of our patients don't follow up on the treatment. So therefore, they are so preoccupied with these clinical visits that I don't think they have adequate enough compliance. Now, when you look at a physician's perspective, if you look at the PAT survey, they said that monitoring visits are the most time and resource consuming part of managing patients with AMD. What is the importance of retinal fluid in AMD? Now, this is a picture of a retina with advanced AMD. You can see intraretinal fluid, there are cysts, there's sub-RP fluid, subretinal fluid, displacement of photoreceptors, anti-VEGF that inhibits the formation of these new blood vessels, stabilizes the retinal morphology, and has basically revolutionized the treatment of AMD. Now, fluid as a component of AMD has been studied in several landmark trials. If you look at the CAT study, 30% of trim or fluid in all compartments, SRF was seen in 82%, IRF in about 3/4 of the patient, and nearly half had sub-RP fluid. The Pronto study also said that qualitative assessment of OCT-B scans was probably better at detecting fluid at the macula than changes in the visual acuity itself. Now, this is how we visualize the retina using the OCT. You can see a normal looking retina above and one with fluid in the different compartments below. Now, some of the examples of intraretinal fluid are intraretinal cysts, macular edema, cystoid macular edema, retinal exudates, and hemorrhage. Subretinal fluid components could be serous, hemorrhagic, or exudates. And then in sub-RP fluid, again, can be hemorrhagic or serous. Now, key retreatment criteria across several of these trials was also fluid. So whether it was the CAT, the IVAN, the TREX, the RIVAL, all of these studies used fluid as a key retreatment strategy. The current society guidelines also, whether it's the EURETINA, the RCO, or the Academy, they also use SRF or IRF or even sub-RP fluid or hemorrhage as a guideline to treat further. Now, what happens now in the real world? Is it any different from what has happened in the trials? Not really. The presence of SRF and IRF was at least 4-fold an indicator of an injection visit versus a non-injection visit. And also, visual acuity loss was not a consistent trigger for retreatment as against the presence of fluid. So which of these retinal fluid is really important? When you look at IRF, it says that, like I mentioned, it accumulates in well-defined spaces called as retinal cysts. The presence of IRF or IRC at baseline is associated with negative impact on BCVA. And both residual or even new occurrence of this fluid could be an indicator of worse visual acuity outcomes. When you look at SRF in these patients, it's a little confusing. Some studies say that SRF at baseline is actually, associate better visual acuity, whereas other data suggests that recurrence of SRF can actually have a negative impact. But what we need to remember is that even in studies where SRF was tolerated, it was still very, very closely monitored. What is the importance of sub-RP fluid? Not very much evidence, I must say, on this particular, fluid component, but whatever little is seen or shown in literature, it can be also a very early indicator of active or recurrent disease. So therefore, all of these fluids are considered pathological and all of them need to be controlled to prevent irreversible vision loss. Now, why we need to control them is because they have a long-term impact on the visual acuity. The presence of fluid leads to visual acuity decline, and a dry retina, on the other hand, tends to provide long-term visual acuity gain and maintenance. Now, looking at some of the other ways in which we can analyze fluid besides an OCT, we can use also AI-based techniques. What it does is measures fluid in 3D. It can actually measure volume, and both the manual and automated methods have shown to have good correlation. This is where they've looked at both high disease and low disease activity in a scan area of 6 millimeters in the macular center. And the IRF, SRF, and the PED volumes were all relevant for visual acuity outcomes. Now, do fluctuations really matter? Do they have an effect on the visual acuity outcomes? They do. Higher central subfoveal thickness variability is associated with lower BCVA, whereas less subfoveal thickness was an indicator of lesser or fewer visits. So why does fluid really matter? Because it helps us formulate treatment guidelines, it helps us when to treat, and also the impact of retinal fluid is on the visual acuity, which we have seen in several studies. Now let's go over to some case examples. This is case number 1, 70-year-old female, decreased vision, right eye since 2 months, had received bevacizumab for the right eye elsewhere. Last injection was taken literally 2 years back. Left eye was already lost to CNV. So this is how she presented to us. As you can see, the left eye is pretty scarred. Right eye is showing some amount of activity, as you can see. This is the old scan of 2019. And the scan when she presented to us in 2020 December, the vision was 648, and you can see a large cystic space there. Within 1 week post-injection of brolucizumab, you can see that the fluid has wonderfully gone down. This is 4 weeks post-injection. Again, there is stabilization of the vision. Case number 2, 58-year-old lady, solid PED with SRF. 3 loading doses were given with another anti-VEGF. The vision was actually 6 parts. So here you can see the 3 loading doses, Jan 2021 to March 2021. You can see there is some reduction of the fluid, but the PED height also has not significantly come down, nor has the disease stabilized. So this is when we saw that there was persistent SRF even after 3 doses. Brolucizumab first injection was given in April 2021, and by May 2021, not only have you seen that the PED has reduced in height, but also the SRF is completely gone with just 1 dose. And this is the image in June 2021. You can see that the PED has further reduced, and this is on last follow-up. Last case here, 68-year-old gentleman, 1 eye, because the right eye was lost or scarred CNVM. Left eye, again, multiple injections of bevacizumab taken elsewhere. We saw this patient in 2020 of June. We could see both, polyps and BVN on FFA and ICG as shown here. What you have to notice here is the very, very large PED. Again, patient had received bevacizumab here. In August 2020, we switched the drug because we felt that, the patient had plateaued and there was no response. September 2020, again, the injection was repeated because we saw some amount of success. And the patient presented again to us this year in January. And by Feb, you can see a massive increase in the PED. So that's when we decided to give a patient brolucizumab injection. 27th February, we gave the first injection. And because we were still using the drug newly, we called for a close follow-up. And by 6th March, you can see a drastic reduction in the PED height and also resolution of the subretinal fluid. This is again on follow-up. Once we continue to see the patient, this was on 20th March. 2 weeks later, the PED had further decreased. This is in May after the 3rd injection, and June after the 4th injection. You can see, sustained reduction, sub-RP fluid. This is on the final follow-up that we saw this patient. So to summarize, we must know that all retinal fluid is considered a disease state and needs to be controlled with appropriate treatment strategies. It is imperative to aggressively treat all of it. Real-world evidence has shown that retreatment decisions are more strongly influenced by the presence of IRF and SRF rather than visual acuity loss itself. And more stable foveal thickness is a better indicator of visual acuity gain. Thank you so much.
Thank you, Dr. Chaitra, for that very nice talk as usual. I think you brought out all the points very well. There's nothing much to discuss on fluid, and time given also is very less. What I would like to ask one question to both you and Sachin also, if he can contribute. It's about the non-OCT markers. Let's say a hemorrhage. We just find a hemorrhage sometimes at the edge of a CNV, which is actually a sign of activity. And we sometimes find an increase in size of the CNV. So what do you do in such circumstances?
I would persist with the treatment, sir. So even if the visual acuity is good, but we have been taught that any new hemorrhage the area of the membrane itself, an active membrane, is an indication of activity. Sometimes I actually find it difficult to convince the patient that it is a sign of activity and you need treatment, but I think we need to persist, otherwise it can get even worse.
What about the size of the CNVM? Sometimes the size increases. Is it the fibrotic component always, or is it some activity
So
also
that
going on?
we see either on Opta to see how mature the blood vessels are,
Right.
or if I feel sometimes I want to think the strategy, I might even do an angiography.
Very well
to
said.
look for
Yes.
activity.
Correct. I think doctor comes in very handy in such cases where
Yes,
you want to rule
Opta
out
does.
activity. Yeah. I think since time is short, I think we have to wind up at 12. So we'll relieve Chaitra and let her attend the wedding. And go to the next talk by
Thank
Dr.
you, sir.
Yes, thank you, Chaitra. Thank you for your talk. Dr. Sachin Mahali is our next speaker, and he'll be speaking on brolucizumab, the new kid on the block. And just to conventionally introduce him, he holds a brilliant academic record. He's my close friend in the neighboring city from JNMC. Thereafter, he had a solid, rich experience of 6 years at the world-renowned Shankar Nethralaya, where he even won the Dr. V.T. Joshi Endowment Gold Medal in the field of retina. And he is currently the director of Netra Darshan Super Specialty Eye Hospital, Belgaum, and also a VR surgeon at the Vision Care Super Specialty Eye Hospital, Goa. He has presented several research papers both at national and international levels. Several publications are there to his credit, and his surgical videos I have been watching with keen interest these days are very lucid and crisp and really a treat to watch. So with this very, very brief introduction, Dr. Sachin, I present to you. Dr. Sachin, please go ahead with the talk.
Am I audible? And my
yes, you are.
Yeah. So thank you so much for that kind introduction. I really admire you as my teacher, and you've been always a guiding source for us. I have been using brolucizumab of late in many cases of PCV, and these are early stages when we have started seeing wonderful results. I'd like to share a few cases which basically on PCV. So this was a first case wherein a 70-year-old gentleman who himself was a neurophysician. He was diabetic for only 5 years, and he is pseudophakic, and his BCA when he presented was 624 in the right and 618 in the left. Just to give a brief history, he had undergone cataract surgery with us some 5 years back. That time he had some macular scars. He said he had undergone some laser, probably for exudative maculopathy. That is what was diagnosed that time, some 10 years back. Probably they had no clear picture what they were doing at that time. So this was the picture when he presented to us. He had a recent drop in vision at that time when he presented. So there were multiple areas of PEDs, and we could see some intraretinal and subretinal fluid along with the PED. There was a ERM and a lamellar type of hole as well. So previously recorded vision before this was 6.9 in his case, wherein a lamellar hole was documented before also. So we did the Opta, and we found that branch, BVN was present, and plus there was the area of fluid and PED. So we did diagnose this as a case of PCV. Probably there was a laser done and a lot of macular scarring, as you can see. So the exudation was not very much. This was his left eye. When we saw, there was scarring, PED, and along with that, there was some intraretinal fluid. So we explained him his condition, and we said there could be underlying PCV or for what this exudation is happening, and probably what he was treated 10 years back was laser was the same thing. Later on, we explained him the need of anti-VEGF injection. I told him multiple options, and he agreed readily for the brolucizumab. Within 15 days, there was a fantastic resolution of the PD, and SRF had decreased, and his vision came back to 6.9 and 6. He's a Horatius reader. He was very happy. I was surprised to see that ERM lamellar hole, and plus he improved to 6.9 vision. So we were very happy that we could read the diagnosis correctly. And even the left eye improved, but the left eye had a subfoveal scar, so his vision did not improve beyond 6.18, but he was quite happy with whatever vision he could regain. This is a case too, wherein a 65-year-old lady presented with single complaint. She was 6.6 both eyes, single complaint of a visual field defect. This is a very interesting case. When I saw, if you see the clinical picture, you can see the PED and an SRF there. There's a wonderful peripapillary PED and a very solitary lesion. Her complaint was only field defect. So we did an OCT wherein we found a tense PED along with an SRF around it. So we were very tempted that it could be a CSR related thing. You know, the choroid was also thick on the OCT. If you see the choroid, it's like something like a pachychoroid. So we thought it may not be a CSR. Then we did a conventional angio as well, and we found that it could be a case of PCV. Octa actually showed us the BVN there, and later on we did we explained the need of anti-VEGF, and we treated her with brolucizumab. Within a month's time, the PED had flattened up completely and wonderfully resolved SRF, and patient's symptoms were almost gone. This is now she's holding on for last 2-3 months. I've been following her up, and last 2 months at least, that the PED has not come back, and the SRF is also very minimal and almost gone. So case 3, this gentleman, he's a very good friend of mine who keeps coming to me. He has already taken some 26 injections in both eyes, all sorts of injections, from bevacizumab to brolucizumab. He's epic. His case paper has become a Bible for us to understand the PCV. He was a known hypertensive. His despite of these injections, he was maintaining his visual acuity at 624, 636 in both eyes. When he presented last, he had an active, sort of SRF and PED. This was his picture, wherein we thought the activity has come back, and this was an Octa image of the same patient. This was 1 month following brolucizumab. You can see the SRF as the anatomical restoration. See this pre and post. If you see, anatomical restoration and the fluid drying effect was amazing. And this is the Octa post injection. Now he had a recurrence after 2 months following injection, and we repeated the second dose at that time. This is Octa when he had a recurrence. The following second injection, he had complete resolution. In fact, the anatomical restoration was better than the first injection what we had seen. So he is also maintaining quite well now. It's been 4 months that we have injected 2 doses of brolucizumab for him. This was his response to aflibercept when we treated him with aflibercept last time when he had a recurrence. So it was good, but the drying effect was not as good as this one in this case. So this is the pre and post injection of the patient. So this is the last case, 75-year-old gentleman. This is recently I saw with sudden loss of vision. He had a massive subretinal hemorrhage along with a thumb-like PED, which was very classical clinical diagnosis of an PCV, which this is within 15 days. The subretinal hemorrhage also sort of started clearing, and it was cleared up with just PED being settling. So we are waiting for further follow-up of this patient. And just to summarize, the experience with brolucizumab in cases of PCV have been excellent. Only worry which I have is I have not seen a case of RPA rib, because the speed with which the PED comes down always scares me for an RPA rib, but till now I have not seen any case. So that would be a point of discussion, and we should be careful in these cases wherein there is a sudden drying effect. So especially in cases of PCV, we should look for those things. Thank you for your patient hearing, sir.
Thank you very much, Dr. Sachin. That was very short and sweet. I think you have covered most of the things well, except that I would like to ask you a few questions about your experience.
Yes,
I will share my experience first, and then I will ask you whether you concur with my observations. When I started using brolucizumab, I initially started using it for patients who are not doing well with the other anti-VEGFs available, and only the non-responders with ranibizumab or bevacizumab or aflibercept I was using brolucizumab for. And that was the beginning. And then later, when I got the confidence to use, when I saw the response to brolucizumab, I started using for treatment-naive patients also. What was your journey with brolucizumab?
My thing was, first I started using brolucizumab, as you said, again for recurrent cases like which were not responding to other anti-VEGFs. But off late, I've been using for naive patients quite frequently. Initially, they were I was very hesitant because some reports of inflammation and all were there. but later on I felt that in our Indian scenario, there were not much of inflammation which was noted. So my first case was AMD, wet AMD, which was not responding to any form of antibiotics, and it respond well with this. So hence thereon I've been using quite frequently now. I've started using various range of diseases also, like myopic CNVMs, and even I've used in an inflammatory CNVM, which worked wonderful. I was very skeptical on using that because it's been
drug itself causes inflammation sometimes.
Yeah.
So since the topic of inflammation has come up, Dr. Sachin, I just want to ask you, initially when brolucizumab was introduced, I think we were all a little skeptical about the causation of inflammation in its usage. So we were, keeping our fingers crossed until we saw that nothing was happening. And after it's more than a year and a half now since brolucizumab has come in the armamentarium of the ophthalmologist, and in between there was nothing. There was no report of any inflammation. But recently we have been hearing talks about again inflammation. I don't know whether it is whether the industry has anything to do with such talks. But then, what is your experience? You must have given hundreds of brolucizumab by now. Have you ever had an IOI in your experience?
Not a single case, sir. I've used more than, as you said, nearly 100 patients now, but I've never had a case of intraocular. I tend to follow up them very closely. I do it on first post-op, and then I call them after 7 days again, and then 15 days again. So just that we don't miss anything because this is a new molecule, so we just need to follow up. In my experience, I never had a case of IOI. How about you, sir?
No, not a single case of IOI.
Yes, sir.
Some of the patients nowadays we are sending away. We're not examining the next day. Initially, we did start examining the next day, but nowadays we are not calling the patient until a month.
Right.
So, and of course, we teach them what we call SAVE in our institute, self-assessment of vision every day. That is what I teach everyone about how to monitor the vision themselves by closing the other eye and checking out their vision and reporting in case of any fall.
Yeah.
I think that is one thing that we practice, and I would urge everyone else also to practice the same. That's one good way of picking up inflammation or even endophthalmitis very early and be able to treat them effectively. Yeah. So I think so. The bottom line is that brolucizumab is both effective and safe, and in its effect, I think it is quite rapid. I think there are some concerns about the rapidity of drying, which might cause rips and all that. But I think you and me, as per the discussion that went on in the last 15 minutes, we have not experienced any rips. Yeah. So, and apart from NAMD, for which it is FDA approved, I think it will probably be soon approved for other retinal diseases as well. In fact, one of the cases which Aitra was showing, the second case which she showed was actually a PCV. Although she diagnosed it as NAMD, it has all the features of a PCV. If you agree with me, I think yes, so. It has worked very well. Brolucizumab was what was given for that case, yes, and yes, I think it worked very well. Anything else you want to say, Sachin?
Nothing, sir. Are you using it as a loading dose, or you're doing a PRN basis? Like
no, I'm a little friendly to the patient's pocket because of the profile of the patients that we see here in our center. Yes. So I think my loading dose will be once in 2 months. It will not be monthly. Okay. The second injection will be not earlier than 2 months, and then that is what I call as loading in my my definition. And after 2 injections, I make it PRN, and it will be at the extension will be every 2 weeks. For example, if it is 2 months to begin with, then it becomes 2.5 months and then 3 months, and so the extension will go on every 2 weeks after the 2 months period. That is what I practice because of the sheer profile of the patients that we treat here. Yeah.
Great, sir. Yeah. Thank you so much. Yes, sir.
Yeah. Okay, Sachin. I think it's 12 now, and we are supposed to wind up. And thank you very much once again, both you and Chaitra. Chaitra may not be there. Thank you for your excellent talk. Thank you, Novartis, for this opportunity. Yeah. And we'll wind up here. Thanks.
Thank you so much, sir.
You're welcome.
Welcome. See you.
See you.